morning, and welcome to the Davies Use Case webinar being presented by Memorial Hermann on central line associated bloodstream infection prevention. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support, best practice guidance, access to clinical data to analyze progress, and IT-enabled safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence, the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar, Suraj Anwar, and I'll turn the presentation over to Suraj to let him introduce himself. And Suraj, the floor is yours.
My name is Suraj Anwar, and I'm the Associate Chief Medical Information Officer for the Memorial Hermann Health System. I co-manage the informatics operations for the system with my two CMIOs for inpatient and ambulatory, respectively. It's both an honor and privilege for me to present on central line associated bloodstream infection prevention, which is one of our case studies for the 2017 HIMSS Nicholas E. Davies Enterprise Award of Excellence. As I go over our case study, I'll begin with some background on central line associated bloodstream infections, or CLABSI as they're commonly referred to. Then I'll go over some of the challenges we faced as an organization with respect to CLABSIs. I'll talk about the governance, design, implementation, and monitoring of our health IT solutions that we worked on to tackle this healthcare issue. I'll also cover some of the financial impacts that we identified as a result of our solutions, and finish the presentation by talking a little bit about our lessons learned and some closing thoughts on informatics and its role in healthcare. All right. Here's a quick high-level background on CLABSIs and why they're important in healthcare. They're quite common if the appropriate precautions are not taken. In 2009, according to the CDC estimates, there were about 41,000 central line infections. 15,000 occurred in the ICU, in the neighborhood of about $45,000 as well, with about 28,000 deaths every year being attributed to a central line infection. Have made significant improvements over the years. Continue to be a problem, and it's quite easy to understand why they're a priority in healthcare. As an organization were primarily due to the complexity of being a large health system with 15 hospitals, and each of these hospitals had different clinical staff, although some of the staff were practicing at more than one of our facilities. But when you factor in that we had 66 ICUs, approximately 965 beds, and about 8,400 central line days per month on an average, that quickly contributes to the variability in the care that is provided for us. So we started on our journey to improve the CLABSI rates in the organization. Well, not so good as this data would tell you. And this data is collected on a monthly basis to show us the number of CLABSIs for 1,000 line days, which was the metric used to denote the infection rate. And while we quickly saw this as a problem, that we as an organization wanted to fix, we first asked ourselves the following question: is this problem even possible to fix? Quickly, published in December of 2006, this article in the New England Journal of Medicine showed that by applying some fairly simple interventions and systematically approaching the problem of CLABSI, this organization was able to reduce their ICU infections down to a median rate of 0 at 3 months. And this is what we wanted to achieve as well as an organization. Design and implementation portion of the presentation, and business model was to make sure that, first and foremost, we an organization about the significance of CLABSI. And we called a meeting with stakeholders from all over the organization and put them all in a big room together. And Dr. Michael Shabbat, who was our Chief Quality Officer at the time, started off the presentation with the following image. It was an oil platform. To be in that audience that day as I got invited. And the association of a burning platform with CLABSI in our organization was quite dramatic for all of us. But I brought the message loud and clear, and it was that we needed to do something about it now. Here's the present for the first kickoff meeting, and these are the same stakeholders that we continued to work with on this initiative as it rolled along. So stakeholders included clinical and operational leadership, physicians, nursing, the quality and infection control teams have representation as part of the governance process and as part of the decision-making process for design decisions. And these were focused on the interventions that were being designed in the EHR, as well as on paper, because most of these processes we started off on paper before we moved into the EHR. Perspective, we conducted joint application design sessions, or JAT sessions as they're called. And in addition to the key clinical stakeholders, we also had application analysts who were experts in the functionality of the electronic health record and the overall technical capabilities of the system. We also had clinical informaticists as part of these sessions to help with bridging the clinical needs and technology piece. Some of the key design decisions that were made at these JAT sessions were around the overall functionality of the intervention and the data elements associated or needed for that documentation. And then finally, what was needed for reporting purposes. While these interventions to help with our CLABSI reduction initiative, there were other things happening in the organization at the same time. And all of these activities contributed significantly to the overall impact and success of our CLABSI reduction initiative. First, this initiative at the board level and with the senior leadership, we made patient safety a priority for everyone in the organization. And at that time, we started our Breakthroughs in Patient Safety program, or the BIPS program. That's what we call it. As part of the employee had to attend mandatory training on the aspects of patient safety and how to apply to them on a day-to-day basis. was to empower our staff and employees to say no if and when they felt uncomfortable performing a particular task that could be a detriment to patient safety. We also knew that there was a single source and type of central line insertion supplies available. Variability. Organization, we are going to use documentation bundles to document each of the steps for the central line insertion procedure, and primarily the ones being performed by the clinician. The infections that did occur to specific physicians and the nursing unit, and practice documentation, we started to hold people accountable. There was periodic review of the data associated with the documentation bundle adherence that showed which patients had exceptions to the expected processes, as well as a monthly report that showed compliance with bundle adherence. And this data was shared at the facility level as part of the monthly operating report for that facility. All the way from the frontline staff to the operational leaders at each of the facilities, and ultimately operational leadership at the system level. Element that we use for the insertion bundle, we have MD hand hygiene. So did the physician wash their hands prior to the procedure? In fact, we also document hand hygiene for the assistant if there was one. The use of chlorhexidine and whether it was dried out before the procedure, whether the physician had gown, gloves, hat, and mask on during the procedure, was the patient draped from head to toe, and maintained during the procedure. And if an assistant was present, whether they had a gown, gloves, hat, and a mask on as well. With the central line insertion, we also created a documentation bundle for central line maintenance because we felt that there were opportunities for infection as well for our patients once or after the central line was inserted. The maintenance bundle are around the insertion site, the dressing associated with the central line, as well as the tubing. Document the central line maintenance for all of our patients with central lines twice a day. The central line insertion bundle is documented only once for every insertion. Here's some initiatives around CLABSI prevention for the organization. We started in May of 2007 with our bundle implementation on paper. We then converted to the EHR in the 2008-2009 timeframe. That's when we were rolling out CPOE as well, but we did have the nursing documentation piece already implemented. Once we in the EHR, we begin our electronic abstraction and the reporting process. In 2013, we made a change to the central line insertion practice when we moved to a new documentation tool in our EHR. We also made a change to the central line maintenance documentation in 2016. The documentation elements previously were spread out across the EHR in different locations for the nursing to document. So we wanted to consolidate it into a single location for, number one, ease of documentation, and then number two, for ease of visualization on what care was being provided for the patient around central line maintenance. When we started, that is when we started documenting physician line necessity also. Because if a patient no longer requires a central line, then there really is no reason for the patient to have the central line. All this time, throughout the course of this initiative, and which is still ongoing, there was and continues to be surveillance of the clinical outcomes related to central line infections, as well as the bundle compliance with the central line insertion and maintenance. So moving along, I'm going to go into the details of how Health IT was utilized. And to implement Health IT, the first thing that we did was to understand the workflow associated with central line insertion and central line maintenance. And that's what this is. This is a swim lane workflow diagram that shows some of the key stakeholders participating in the process of central line insertion and central line maintenance. It also shows the steps taken in this process, starting all the way from the decision to insert a central line for a patient, all the way up to the removal of the central line. So here's the list of the IT interventions that we created and where they exist in the clinical workflow, as well as the stakeholders that are impacted by the intervention. So number one, we created the central line insertion documentation bundle. Number two, we created daily exception reports that helped identify the outliers for the central line insertion bundle. Number three, we created the maintenance documentation bundle. And then number four, we created daily exception reports for the central line maintenance bundle as well. Number five, we created a method for the physician to document central line necessity. And then finally, number six, we created a daily central line necessity report for our infection control team to review and monitor the central line necessity documentation on an ongoing basis. Here's a screenshot of what the central line insertion documentation bundle looks like. Some of the highlighted questions, we have whether the patient was draped head to toe, or was the sterile gown, gloves, and mask worn? Was the skin prep dry before insertion? And the last one on whether ultrasound was used was added after new evidence suggested that the use of ultrasound during central line insertion reduces the risk of complications associated with central line insertion, specifically for the internal jugular vein. Here are the process measures associated with the central line insertion, and we shared this information in the form of a scorecard. Each row represents the process measure, and the columns represent nursing units or facilities, depending on how the data is rolled up and on the audience that is actually seeing the scorecard. And for Memorial Hermann, blue is a perfect 100% compliance. Green means there's still opportunity for improvement, and a yellow means that attention is needed. So as long as we see blue and green on this scorecard, we are good. Here's a screenshot of what the central line maintenance bundle looks like. And this was after our revision to compile all of the elements of documentation into a single location for ease of documentation and viewing for the nursing staff. Some examples of questions for this bundle was dressing occlusive and intact? Was the dressing changed as per the policy? And was tubing labeled with insertion date? Similar to the process measures for central line insertion, we created a scorecard for central line maintenance as well. Each row here also represents the process measures, and the columns, again, represent the nursing units or facilities depending on just how the data is rolled up and who the audience is. Again, the blue and the green and the yellow, you see more of blue and green, we're good, but yellow needs attention. This is a screenshot of the central line necessity documentation form that was created for our physicians. It shows the kind of central line that the patient currently has with the insertion date and duration. And this information essentially helps the physician to decide whether the central line is needed or not. And depending on their decision, they could document a yes or a no. One of the drawbacks for this documentation form is that the way that it is built, the physician has to remember to document this necessity. And the way that they do this is they actually have to select an order for central line necessity. And when they select this order, this documentation form opens up for completion. This is a screenshot of the reporting tool that our infection control staff uses, and it provides them the ability to run ad hoc reports that enable them to monitor as well which of their patients have a necessity documented for that day and by whom. And if there's no necessity documented for the patients that they've identified as having a central line, then they can have that discussion with the physicians to determine if a central line is still needed. Even when a yes is documented, the infection control staff is empowered to have those conversations with the physician to determine if that is the best course of treatment for the patient. Now, with respect to the central line necessity, we do have several next steps, one of which is we want to be able to automate the documentation of the central line necessity, because it's still a manual process which requires the physician to remember documentation of the necessity. So the way that we're thinking about automating this, and we're currently in the midst of doing a thorough technical feasibility analysis, is that we want to be able to, number one, identify all of the patients that have a central line on a daily basis. And we'd like to alert the physician when a central line necessity documentation is needed for that specific calendar day. We do have some options currently, and they could be at the point of time when the patient's chart is opened, or when any order is selected or signed. And we're also considering doing some passive notification through either email or pager or through our secure text messaging application. One of the biggest challenges that we have right now is knowing which physician we should be sending these alerts and notification to, especially in the situation of these critically ill patients where we have multiple physicians taking care of the patient. So more work to be done. Yeah. This is what our central line insertion bundle compliance looks like over the years. You can see that from the time that we started tracking the compliance, we were at about the 75th percentile. But we've moved it up into the high 90th percentile and have actually kept it at that rate. You'll see a little dip there. That's during the time that we made some changes to our central line insertion bundle documentation, which I will talk about briefly further down in my presentation. Bundle compliance data started initially as sample audits with human observation, and then we moved to electronic extraction. And then finally, as I stated, we created the bundle, which was located in a single place, and started to extract that data. The break that you see in this data here represents when we moved the maintenance bundle into that single location for ease of documentation. We were in the mid-80th percentile and have moved into the 90th percentile with our maintenance bundle documentation as well. Reducing our CLABSI rates is shown here. A downward trend with some occasional spikes. We turn our attention to it and do a further dive, and it goes back down again. Of course, this kind of performance improvement work requires constant vigilance. So when we do have any patients that are identified as having a central line associated bloodstream infection, we do a common cause analysis on those charts as needed, and we try to identify what the failure points were and work on eliminating those failure points. So this is an ongoing process. This work never ends. We just have to be constantly vigilant about tracking these CLABSI. As part of that was described in the Memorial Hermann overview, we created Certified Zero Awards for what we call Certified Zero category, or never events, or as they're commonly referred to. Bloodstream infections were one such category. Now, receive this award if they've had no CLABSIs for 12 consecutive months. So it looks like we've given out 25 Certified Zero Awards for CLABSI prevention over the years. In fact, this here is a graph of CLABSI rates for one of our facilities. It is not an anomaly. It is not a blank graph. There's actually data there, but it's all at zero because they were able to achieve zero CLABSI hospital-wide for 17 months. Of course, 17 consecutive months. Definitely a significant achievement. Moving on to the financial impact, what we did to determine the financial impact of this work is that, for simplicity, we looked at calendar years 2015 and 2016 and compared it to the calendar year 2007, which was prior to our initiative to reduce CLABSI. So with central line days approximating about 8,400 and infection rate of 0.92, that is about 8 infections a month. And when you compare that to the baseline infection rate, which was at about 5.79 for the same number of central line days, that's about 49 infections a month. This is a projected difference of about 41 infections per month. So the infections avoided for calendar years 2015 and 2016 would be about 984, and the cost avoidance at approximately $45,000 per infection, it amounts to a total of about $44 million. So quite a significant amount. Lessons learned: to have stakeholder buy-in when designing EHR interventions. And success cannot be guaranteed. Once you start collecting the data, you must use it to drive improvement because you need for improvement. And once you find that out, it's about actually making those improvements, further improvements. And be able to hold people accountable, which is another key component for success. And to make changes to your data element because there was a change in clinical practice or as a result of changes to the overall process. And we had these reasons about 4 years ago to our central line insertion documentation bundle. These changes were made about a week prior to the Memorial Day weekend. And what was that these changes broke all of our reports for the central line insertion bundle. We actually spent Memorial Day weekend fixing the report. So my key lesson, key takeaway to all of you when making changes to quality reporting and the data elements associated with quality reporting is hold your horses. And that's just not because we're here in Texas, but you have to carefully consider what these changes will do to your reporting. And when you have the system and the people within that system looking at that data closely and using that data to drive their performance, if you are not providing that data to them because the data is not right or the data isn't available because you broke the report, people get really unhappy because they want to know how they're doing. So remember that. Informatics, and we all know that informatics plays a pivotal role in the implementation of health IT and quality improvement. They say that informatics is the intersection of people, process, and technology, but when you look closer, there are people behind the process and people, again, behind the technology. So essentially, informatics is the intersection of people, and people. But what drives these three pieces together are the relationships between those people. And without those relationships and the trust between those people, we wouldn't be able to provide highly reliable care for our patients. My presentation. Thank you.
Well, thank you, Suraj, for that great presentation. I just want to remind folks where to go find this recording, this presentation, and other valuable Davies use cases. That information can be found at .org/. You can find that information plus information on how to apply for Davies. So again, thank you for that great presentation, and this concludes this recording.